troubleshoot. Any new consults today? On you. You kind of feel. Good morning, y'all. Welcome to another day of my life. Today is a good day. I am here and I only have 2 days I'm going to be working this week because I'm actually going to be starting an intensive board review, course review that the AHPM is throwing from Wednesday to Saturday. And this is something I really need to do because boards are only offered one time per year, November 10th to be exact, and I have signed up for it. And it's a pretty hard one from what I've heard. And not so hard because of the content. I think it's just kind of like the preparatory materials. They're not very centralized as compared to when I was preparing for my internal medicine boards about 2 years ago, maybe 3 years ago actually. But I'm looking forward to it. I went through their initial kind of pre-recorded material, and the setup of it is that they actually have full days where it's going to be all live, and I'm going to see if I can try to record it so I can rewatch it later on in the year. But I'm excited because I haven't had like a dedicated study period in quite some time. So regardless, I'm just getting here to the hospital. I'm on the inpatient palliative care service. I'm running a little bit late, but regardless, I'm going to see how many consultations we have. I had about 2 yesterday and I signed off on 1. So I'm hoping today isn't as busy, but if it is, then I get some good learning out of it. Any new consults today?
A couple of rollers. Andrea and I looked at one yesterday, or actually we were going to go see one yesterday.
I know I signed off on 1 yesterday and the other one's kind of watching. So I can pick something up today. Get some learning in.
They notice that? Because sometimes they don't even notice that.
Yeah, it's really nice when the primary sheet looks at our notes.
Yeah. Actually look at the LCP section and see if stuff happens. Should we start? All right. They're consulting for hospice. So I can go see this one too. Small world. The list is set. We have kind of a small list today. I think looking at our list, we only have 13 people right now, which honestly, I'm not too mad at it. I'm going to be seeing 3 of those people, and then the rest of them are being divvied up between our nurse practitioners, our nurses, and then our social workers and chaplain. And one of our doctors isn't here today. They actually had to call out, so I'm going to be the main doctor for today. The 3 people that I'm seeing today, one of them is just a follow-up from yesterday. It's just more so going to be seeing if they had a discussion with their family member about their code status, whether or not they want to be full code or do DNR, DNI, which essentially means that if their heart stops, if they would want a natural death or they would want to go through all the CPR, intubations, and really invasive measures to try to come back to life. So that is the main thing that I'm going to follow up on. I think the main thing that I learned from that case is that with a lot of our patients, we have to think of things in a full comprehensive approach. And one of the things that we have to actually discuss is whether or not someone's faith or spirituality affects the way that they make medical decisions. And one of the things that I learned specifically for Catholicism is that a lot of people with that faith have feelings about DNR, DNI, and feeling whether or not that's hastening death or choosing like suicide or euthanasia, which is actually not the case. And one of my chaplains, and this is why it's so important to have a full multidisciplinary team, our chaplain, he is well versed in Catholicism, and he actually was able to pull up the specific doctrines that talked about end-of-life care. And one of the things that the Catholic doctrine teaches is that you actually have to think of making medical decisions, whether or not it's based on extreme extraordinary or extraordinary care. So extraordinary care would be invasive measures that would try to prolong life without the quality of life. And ordinary measures are if we would just take this and it's not too burdensome, that it would be meaningful and it would actually be permissible under their faith. So that's one of the things that I learned, is that we have to learn who the patient is, specifically what their spiritual or religious backgrounds are. And based off of that, they can kind of determine whether or not how that affects their medical decisions. So that's something that we ask in palliative care. So I'm gonna go follow up with that patient. The other patients that I got today are both new consultations. One of them is more so a hospice discussion for someone with metastatic colon cancer. And it sounds like they actually refused hospice a few months ago because they felt a little bit stronger at that time, but since then they have declined. So today I'm gonna go talk to them and see how they're doing, see what their thoughts about hospice are now that they've kind of had a decrease in their quality of life. And whenever people come into the hospital with any sort of stage 4 or metastatic colon cancer, or not even just colon cancer, just cancer in general, once it hits stage 4, it's spread beyond the actual originating site of the cancer. And once you hit that point, there's no cure, and it's actually doing things in a more palliative intent. So whenever someone is doing chemotherapy or doing any sort of like immunotherapy or treatment for cancer that's already stage 4, usually it's always palliative intent, meaning that they're trying to shrink the tumor or shrink the cancer so you don't have a lot of the side effects, meaning like shortness of breath, pain, nausea, vomiting that can come from the actual cancer. So oftentimes it's more or less a risk versus benefits discussion of when to do hospice at that time, because once you hit stage 4 metastatic colon cancer or any cancer in general, you are automatically, you are eligible for your actual hospice indication, unless it's more so a metastatic cancer that is just purely going to the bones, because when it goes to the bones, it's really uncomfortable, but it's not really life-threatening. So oftentimes they can live for years and they don't actually meet the indications for 6 months or less. So this patient I'm gonna go follow up on, see what their discussions are, and then maybe include the family to see what they think as well, because where they're going to do hospice is also going to matter as well. And then the last patient that I'm going to be seeing, that was the second patient. The last patient I'm going to be seeing is another goals of care discussions. This is a patient that came in for a stroke and is now bedbound, not really interacting at all. And when we think about when someone is ready for hospice from a stroke perspective, the first thing we think about is what is their functional status? And the functional status meaning how interactive they are, how are they able to take care of themselves, how strong they are they bedbound? So if they're bedbound, or if their functional status is less than 50% and they're not able to maintain any sort of meaningful nutrition, meaning that they're not able to eat orally or drink orally, and that they don't want any medically administered hydration or nutrition through like IVs or a feeding tube. Oftentimes if you have a stroke, because stroke patients can have dysphagia or issues swallowing in like the first couple of months after a stroke, sometimes they get a PEG tube and they get artificial nutrition as they wait for that swallowing reflex to come back normally. And if they continuously lose weight and they're having more and more malnutrition despite all that, or if they don't even want the feeding tube through like a PEG tube or a nasal gastric tube, then oftentimes that means that they are going to not getting enough nutrition and their prognosis would be days to weeks. So that would also make them a hospice candidate as well. So I'm gonna go have 2 hospice discussions and another code status discussion today, and then we'll see how the rest of today goes and see if any new consultations come in. Okay, that is 2 patients down. Well, technically 1 patient down. I signed off on that first patient that we were talking about earlier about their code status change. So after talking with them and after they had a discussion with their family, they're actually opting to stay as a full code, but actually as a trial period. And that's one of the things that we kind of do to kind of meet patients on a middle ground. A trial period for a full resuscitative measure essentially means that we will do the CPR, we'll intubate you if needed, but we usually have a defined region and defined mechanism for what a trial period usually means. Now, trial periods essentially means, especially in the context of being intubated, whenever you get intubated, which is usually for multiple different reasons, either you're hemodynamically unstable, meaning that your blood pressure, your respiratory rate, your heart rate, that's all out of whack. You can't protect your airway, so that usually happens if you are not mentally fully there and you can't protect your own airway, so you get intubated for that. And then you can have respiratory issues. So are you having like a severe lung issue or pulmonary issue where you need to have a ventilator control all your breathing for you? So usually whenever we leave that intubation device in, you can't have it in there for too long, or else it'll lead to something known as tracheal stenosis. And essentially what that means is that when you have something foreign in your airway, if it's in there for too long, it starts making things very, very hard and stenotic. And once we take that device out, it becomes very difficult for you to breathe on your own. And then it makes you a critical airway, meaning that you are at risk for a lot of issues if we need to re-intubate you again. So the remedy to that is that usually we do a tracheostomy, which essentially means that we'll take out the intubation device and we'll surgically create a hole right here and put a device there. That way we can connect that to a ventilator if needed. And if not, if you don't need a ventilator, then you just breathe directly through that. Now, a lot of people are okay with that, and some people are not okay with that. The thing that you have to really think about is that getting a tracheostomy is not like, oh, we just surgically create something for you there and then you can just go on your merry way. Oftentimes it's not like that. I would say probably almost all the time it's not always like that, because that's a major surgery. Oftentimes, because you've been in the bed with the actual intubation device, is when you're laying in bed, you're not using all your muscles, and then you start having muscle wasting. So people become very, very weak and debilitated after being intubated for so long. So oftentimes when you get the tracheostomy, you have to go to a nursing home because you're gonna need a lot of support, because you're not strong enough to just go back home and just start doing your things as normal and possible. And a lot of times people don't like the idea of going to a nursing home because they lose their agency, they lose their independence, and you have a lot of issues that can come along the way, such as hospital-acquired pneumonias or ventilator-associated pneumonias. You get a lot of issues, like a lot of infections, and when you're laying in bed, you can possibly develop like a sacral ulcer. So it's a lot of complications after the fact that you really have to think about when you get a tracheostomy. So whenever we talk about a trial period, these are all things you have to bring up to the patient and say like, hey, okay, you want to do a trial period, you're okay being intubated. What do you think about the fact that you may not be able to come off the ventilator? And if you are able to come off the ventilator, you're probably going to need a tracheostomy after the fact and be at a nursing home for maybe months on end, have to have maybe a couple of hospitalizations from infections from a lung standpoint. What do you think about all of that? So we just have to make sure that we properly educate the patients before we kind of go on our merry way and say like, hey, okay, you want to do a trial period, this is what it entails. And everybody has their own agency. After they have informed consent, they can make their own decisions. And you don't want to try to go in there with an agenda trying to push somebody. You can just say like, hey, this is all the information, and then every human has the ability to make their own medical decisions. So that is the kind of framework that we have whenever we talk to patients about a code status, intubation, CPR, resuscitated efforts, and everything that you have to consider when you are having these discussions, because you want to make sure they're fully informed so they can make the best decision for themselves and their families. So that patient is going to be staying as full code. I gave them all the information they needed. We had the discussion. They were fully informed and they still want to make their own decisions. So they're going to stay as a full code, which is fine for us. We always lend them a card or anything like that, just kind of let them know if you want to have more discussions like this in the future, then that's perfectly fine with us. Just know that if you make this decision now, you can always change it later on down the fact. And one of the things that makes it difficult for patients to make these decisions is that oftentimes, if they have already gone through a code and their heart is stopped and they died in that moment, then if they do come back and get back to a good quality of life, oftentimes they're going to be okay doing all of that again, because they're like, hey, like this worked for me last time, why not do it again? And the only difficulty with that is that as we age and get older and older and older, the chances of surviving a code and actually being discharged is very low. The statistics are kind of variable, but from what I've studied, if you have a code and your heart stops and you die in the hospital, doing CPR you're able to come back in the hospital about 15% of the times, maybe up to like 20% of the times, and survive to discharge. If you're outside of the hospital and you have a code and your heart stops, then oftentimes the chances of you surviving is like 10%. And if you're elderly, then the chances of having a return to life and survival is actually less than 5%. And if you actually have cancer in addition to all that as well, then the chances of surviving is actually less than 2%. So very, very dire numbers. And I don't share all these numbers with patients unless they ask for those numbers, because some people are very number focused and other patients are. So if they want to know the statistics, I'll ask them like, hey, do you want to know the numbers behind that? But most of the time, patients aren't really fixated on the numbers, and they're more so fixated on what is my life going to be like after the fact. So more so leading up to that quality of life aspect that we more so hinge on and have that discussion on. So that is the main thing that patients are worrying about. He was able to come back to a completely, I wouldn't say completely normal quality of life, but a good semblance of a quality of life that was acceptable. So he is okay doing the full resuscitative measures. But the limitation that he did place was that he wanted to do a trial period. So if he was just like full resuscitative efforts, no trial period, just go full force ahead, I'll be like, okay, maybe he has like some unreasonable expectations because of those statistics I shared earlier, but he put the limitation of a trial period. So that actually shows that he has insight. He's not fully there of wanting to do DNR selective treatment, but he does see some insight in the actual case. So that's something that we continuously work with someone. I don't ever go in there expecting to change someone's code status from jump. I just more so go in there, have the conversation with them, and just share with them all the proper information so they're making good, informed decisions.
So, I was just kind of checking in with him. I think from a physical standpoint,
So I've never actually tried kombucha before, and our hospital has this brand that they partner with. I think it's called Kevita. So I'm a little nervous. I got the raspberry lemon flavor mostly because I like those two flavors whenever I drink juices. Ooh! Oh shoot, I should not have shaken it. Yikes. It's not bad. It's not bad. To be honest, I don't even know what kombucha is, but whatever this is, it's not bad. I am halfway throughout the day. I saw 3 patients this morning. I saw that patient that I signed off on that we talked a little bit about earlier. I called 2 family members for the other 2 consultation services. I wanted to talk a little bit about the cancer patient that I'm seeing with metastatic colon cancer. So they're going into hospice, but I got messaged by the primary doctor that they're actually in a lot of pain. But interesting enough, they said that they don't want to try any opioids, specifically hydromorphone and Dilaudid. And when I was asking why, they were saying like, oh, they actually don't want to do it because they are scared of it causing constipation, which is a common concern that comes with opioids. So one of the things that I actually wanted to do is this person is having chronic cancer pain. So even though they're having a lot of pain right now, they're probably going to need a lot more long-acting pain medications. So one thing that I actually wanted to try today, which I don't really use too often, is actually a buprenorphine patch, also known as Butrans. And they come in different doses, 5, 7.5, 10, 15, 20. And the reason why I like using buprenorphine patches in kind of situations like this, where buprenorphine is a opioid, which is a partial mu agonist. Mu receptors are kind of spread throughout the body, and they're responsible for kind of pain management. But because they're in different parts of the body as well, such as the GI system, you can get constipation as well. So because it's a partial mu agonist, it is not a full mu agonist, such as morphine, methadone, Dilaudid, hydromorphone, fentanyl. So with those other medications, when you're on them for long periods of time, you can have constipation, which is a huge issue. However, with buprenorphine, since it's a partial mu agonist, it has kind of like a ceiling effect on the decrease that it has on your respiratory status, as well as constipation. So this is something that I wanted to try out today. Usually the people that I consider using buprenorphine pain patches for, and you can use
the buccal, the Butrans, and as well as the sublingual for pain management. Buccal is kind of just like in the inside of your mouth. Butrans, the transdermal, you just kind of place it somewhere on your skin. And the sublingual is kind of like a film that goes underneath the tongue. So usually for the Butrans patch, I usually think about it for elderly populations. They're having a lot of side effects from normal full opioid mu agonists, such as morphine, all those other medications we talked about. They have renal issues, so kidney issues. A lot of the different pain medications, such as morphine or Dilaudid, they can create certain breakdown products that are cleared through the kidneys. So if your kidneys are not working properly, then those breakdown products can build up in the kidneys and cause a lot of issues such as hyperactive delirium, such as seizures, myoclonus, as well as agitation. So oftentimes we try to avoid those medications if there's renal issues, especially our dialysis patients, so we don't have those side effects. And then some of the other things that we think about as well is if they're not tolerating the other opioids. Those are all kind of situations, a lot of different other indications as well, but this is a situation where it'd be perfect because they're a much older, frail population, so using full opioid agonists may be a little bit too much, where we have a lot more side effects as opposed to the benefits that we're trying to get for. So some of the side effects that you would usually look out for are sedation, respiratory depression, and then a lot of like nausea can come with those medications as well. Interesting enough, buprenorphine also can cause nausea, but they're not as severe as the other opioids. But regardless, I am gonna eat this lunch. Remember, I have to remind myself never to shake this kombucha because I didn't realize it was caffeinated, or it was actually, yeah, I didn't realize it was caffeinated. Or carbonated, sorry. But anyways, I'm gonna eat this lunch and then head back to the office and see if there's any new patients. It sounds like there's another hospice patient that they want us to see in the emergency department. So my nurse is actually seeing them right now, and then I'm gonna go see if I can certify them for hospice or not, if that's something that's within their goals of care. And what we're eating today, we're having quesadillas, chicken quesadillas with salsa and sour cream. I'm trying to get my protein intake up. I actually bought a bunch of ground beef. I'm gonna make jollof rice today, part of like my Nigerian heritage. So I need to have like a lot of food for the rest of the week, because today is actually my last day on the service throughout this week, because from Wednesday to Saturday, we're actually gonna be doing an intensive course review that we talked about earlier. So I'm gonna see if I can get as much experience as I can. I wish I can be here throughout the week so I can kind of see how my patient responds to that buprenorphine patch, but I'll just talk to my team next week.
Trusted, or would you rather find out industry? Drawn to or attracted to is somebody that is familiar. Wage. And that's where I do have to.
Okay, so I'm just getting back home, and I was actually wrapping up at the hospital with the team, and I actually just realized that today was actually the last day on that actual rotation. So that was a little bit of a shock to me, because they asked me like, oh, hey, are you gonna be back? And I was like, oh, wait, no, next week I'm actually gonna be at the nursing home, which is gonna be a completely different team. And I was actually kind of sad, because I was like, dang, I've been on this service for like a couple of weeks now. I was here a couple of months ago. I really like the team. And when something is like the last event that's ever going to occur and it like sneaks up on you, you kind of feel some type of way. So I just spent a little bit of extra time, instead of just leaving right away, talking with the team, just kind of expressing my gratitude for everything that I've learned towards them. And I'm just really happy that I was able to kind of rotate with that team. So I wanted to take some time and just talk about a reflection for the rest of the week. One of the things that I'm going into the next year trying to, kind of keep at the forefront of my mind is, how am I going to not only grow as a doctor, but also grow as a leader? One of the things with palliative care is that there's not really a pecking order, but there is kind of a pecking order because the doctor, yes, is the one that's going to be signing a lot of orders, co-signing a lot of things. If there is some sort of like issue, the team will reach out to you to kind of ask like, hey, what do you think we should do in this situation? And one of the things that I want to do going into next year is that I'm going to have a lot of different teams. I'm going to have nurses, nurse practitioners, social workers, chaplains, and I want to be able to be a team leader that not only helps kind of keep the team vision kind of aligned, but also how do I serve as a leader that's going to push the growth of everyone, not even just myself. And one of the things that is very important when you're a team leader is that you have to lead in humility. And one of the things for me is that I haven't been in this field for even like a year yet, specifically hospice and palliative care. But the team members that I'm going to be having are very, very experienced in hospice and palliative care. Even though they're not like doctors, they do have a lot of experience. And this is a field that experience really matters. So relying on my nurse practitioners, relying on my nurses, relying on my social workers, other physicians that are on the service, that's going to be quite crucial for me. So at least for the first like 2 to 3 years that I start in this attending job, I'm going to be taking the approach of I'm just here to learn and be a sponge. Yes, I know a lot of the technical aspects with hospice and palliative care, who's eligible for hospice, what medications to use for pain, nausea, vomiting, terminal delirium, palliative sedation. But there's a lot more to that than just putting in orders and hoping that they work. There's the psychosocial aspect of things, the spiritual aspect of cases, and a lot of different aspects to a patient's whole comprehensive care that even though I've been a physician for a while, I'm not trained as a chaplain, I'm not trained as a nurse, I'm not trained as a social worker. So I have to recognize where my niche is and rely on the team members that recognize that they have certain skill sets that I don't have. So I'm really looking forward to that. And the teams that I'm going to be working with next year are going to be quite familiar, except for my outpatient team, because here at my fellowship program, we actually don't do a lot of time in the clinic for specifically the clinic that I'm going to be working in. But I was able to meet a lot of them, and then even tomorrow I'm going to be going to a retirement party for the physician that I'm actually taking over her job. And I'm going to be taking that time to not only just like commemorate and just really celebrate that physician, but also take the time like, hey, like, let me meet everybody else that's here. A lot of times we meet people for the first time in like a work sense and not like really in a social setting. So being able to meet people in a place where we're not surrounded by work, we're not surrounded by obligations, we're just here to celebrate and have a good time. That's going to be a great time for me to meet more and more people that I'm going to be working with in the future. And I believe that to be able to work on a good solid team, you got to have some good camaraderie at least. You can't really have tension or just off feelings. So I really just want to make sure that I put my best foot forward, meet everybody, and just introduce myself and say like, hey, I'm going to be taking over this position. I really want to learn as much as I can from you guys. And, you know, I really hope that we can grow together. And just like I will bring some things to the table for you guys to learn in terms of how my approach is going to be, I hope that you guys can show with me what your terms and approach can be as well, so I can learn from you guys as well. So that is just something that I was just reflecting on as I finish this week. I'm going to cross off the actual week. I have like kind of like a de facto like kind of like cross off and like track list until the end of this actual fellowship program. And after this week, just looking at it, I have 1, 2, 3, 4, 5, 6. So after this week, crossing off is going to be 5 weeks left. And actually one of those weeks are going to be a vacation week. So that's going to be in 2 weeks that I'm looking forward to. So a lot of things to look forward to. I did want to talk about one more topic for today, which I actually want to sit down and talk to you guys about. Something that I learned and something that I just wanted to share. And a lot of the things that I hope to do with this channel is to not only give you guys a look into how my day in the lives is as a hospice and palliative care doctor, but also to kind of give you guys teaching points so you can kind of know what we're thinking from our side of things, and you can actually kind of recognize, okay, this is something that I learned from Dr. Tochi and I can take forward with me so I don't, you know, get confused if it does come up in the future. And the thing that I wanted to talk about are opioid reactions. Now, a lot of the times when we come into the hospital, we see a lot of people that come in with allergic reactions to certain medications. Oftentimes we see it mostly with antibiotics. Sometimes we see it with certain like subsets of medications, but mostly it's with antibiotics. But now that I'm working in hospice and palliative care, I actually see it a lot more frequently, or maybe I'm just noticing it more because I'm actually in charge of these medications, is that people say that they have allergic reactions to opioids such as morphine, hydromorphone, Dilaudid, fentanyl, all those different medications, all medications that I'm going to be using to manage cancer pain and a lot of terminal end of life pain. And when I was studying for my actual board examination, I came up on this actual article talking about opioid reactions, and I wanted to share with you guys what I learned from there. And a lot of the times, what we think is an allergic reaction actually isn't an allergic reaction. And I think it's important that we talk about that, because if we say that we're allergic to a medication that we're not, then you are just limiting yourself from actually being able to utilize a medication that could be potentially very beneficial for you. So there's 3 different types of reactions that you can actually have with opioids. There are non-immune mediated reactions, there are immune mediated mimickers, and then there's immune mediated reactions. And just to kind of fast forward, immune mediated reactions, the lax category that I just mentioned, are actual allergic reactions. The previous 2 are either reactions that you just have with opioids as a just normal adverse effect or side effect. And then there's also mimickers that people may think that you are having an allergic reaction, but it's actually truly not and can be managed with a lot less invasive medications. So let's talk about the first category. The first category is just normal opioid reactions. Now, these are just reactions that just happen as a result of the reactions that you have with the opioids on the mu receptors. Now, opioids are mu receptor agonists, meaning that they go to the mu receptors, they go onto the agonist, they combine, and then they amplify the action that you're trying to have at that specific site. They are spread throughout the body. They're in the brain, they're in the GI system, a lot of different parts in the body. And based on where that opioid reaction hits is where you're gonna have that reaction. Now, a lot of the times, the side effects that you can actually have as just normal opioid reactions are, you can have nausea, you can have sedation, you can have drowsiness, you can have respiratory depression, meaning that you're not breathing as strongly, and you can have constipation. Those are all reactions that we're expected to have with opioids, the longer that we're on them and the higher the dose that you go on them. If you give someone like a very, very high dose of IV morphine, then a lot of times they will become very, very sleepy and somnolent. And then some of them will be even constipated and not have a bowel movement for a couple of days. And then some of them may not even breathe very, very fast. They'll just end up breathing very shallowly. So those are all reactions that we expect to see from opioid reactions. Now, the second category, and just to mention as well, that first category is not an allergic reaction at all. That's just a normal adverse effect of opioids. So that is the first opioid reaction that you can have. The second opioid reaction that you can have are immune-mediated mimickers. So this is the category that actually mimics what people think is a true allergic reaction. The type of symptoms that you can have with mimicking is you can have erythema, so people's skin can turn red. You can have hypotension, which does show up in the actual immune-mediated reaction, such as the allergic reaction, but it's much, much more severe. You can have hypotension, you can have bronchospasms, meaning that the bronchi that are in your lungs, they're pretty much your lung units, they start spasming and people can have an issue breathing. So those are the 3 different things you can have. And you can also have pruritus, which is also known as itching. So those are all things that mimic an allergic reaction, but they're not a true allergic reaction. And most of the time, the things that we can do with that is just do antihistamines for the itching. And you can actually just give fluids as well for management of those opioid mimickers. So those are actually the other categories, but they're not a true allergic reaction. And then the actual allergic reaction, the immune-mediated response to opioids, is what we actually are really, really concerned with. And if we see that, that is a true reaction. So the first thing that you can actually have is atopic dermatitis. And atopic dermatitis is a very, very severe skin reaction. Like I mentioned in the previous category, you can have erythema, which is just kind of redness and itching of your skin. But for atopic dermatitis, that is actually a true reaction. You have kind of thickening of your skin, very, very itchy, and that is actually
a lot more widespread as opposed to more localized with the more erythema. So that is one of the true immune-mediated reactions, also known as a true allergic reaction. And then the second thing that you can actually have as well with actual immune-mediated reactions is anaphylaxis. So anaphylaxis is a very, very severe infection. Like I mentioned before in the previous category, you can have hypotension, but you can have hypertension, you can have dilating of all your blood vessels, and you can have breathing issues that can go and open up the blood vessels in your heart way too big, as well as in the GI system. So that is a true allergic reaction, and that is actually something that is life-threatening. And the things that you can actually do for those two true allergic reactions is usually IM epinephrine, so intramuscular epinephrine. And if you can even do IV if you're in the hospital. But usually intramuscular epinephrine is something that people use on the outside hospital, especially if you know you have allergic reactions to medications. Boom, right in the thigh, you inject it, and really, really quickly, it just resolves everything. And if it's a really, really bad allergic reaction with anaphylaxis, you may need even to be need to come into the hospital to be on a continuous infusion of epinephrine to break up that allergic reaction. And that's actually one of the 4 types of shock that you can have is the anaphylactic shock. So that is something that I just wanted to share, because whenever we see someone that comes in with a documented allergic reaction, and a lot of times in the hospital, whenever they come in, they won't even say what happened specifically as an allergy. So whenever you see someone in the hospital and they say like, hey, I'm actually allergic to that medication or allergic to that medication, say, okay, what actually happens? Are you just having constipation? Are you just having some mild itching? Are you just like a little hypotensive? Are you just having some issues breathing, like very minorly, that you can just take an inhaler for? What actually happens with that? Or are you having like a full swelling, hypotension, your mentation is going down, you're not breathing very well, having those bronchospasms very, very severely? That is a true allergic reaction. So if you're hearing any semblance of that, that is something that you should be aware of. That is something you should be concerned about. And that is something that you should mark into their chart and say like, hey, when they get IV morphine or IV Dilaudid, this is actually what happens. And if you document that, no one's gonna use the medication again. But if you're having a very mild reaction, and if you're having either like the mimicking area or like the non-immune mediated reactions, then oftentimes you can just try to manage those side effects that you get, as opposed to just stop using the medication entirely. So that's very, very important. I just wanted to share with you guys that today. So in terms of just a little bit of an update for the rest of the year, I just wanted to kind of share with you guys how the rest of the year is going to look like. Next week, I'm going to be going to a nursing home for the palliative care team with this actual private company. We're going to be bouncing between 2 different sites. I haven't done a nursing home rotation ever in my medical career, so this is going to be a little bit different for me. I'm not nervous or anything. I'm just kind of curious how the skilled nursing homes actually work in terms of consultation services. So they actually gave me this big laptop here that I'm glad I didn't forget at the hospital, because I'm not going back to that hospital. So they actually gave me this full laptop here, because you can't actually just use your normal laptop to try to log into their hospital network. It's very secure. So they gave me that. They gave me another phone right here. So I have a work phone that I'm going to be using to communicate. And the week is not going to be extremely busy. I think looking at my calendar, to be exact, on Monday and Tuesday I should be going in. Wednesday we do have lectures, so I won't be showing up that day. Thursday I will be going in, and then Friday I will be going in, and then I'll be flying out that day as well. So it's going to be very, very fun, because the week after that I'll be on vacation, and I'll be gone for a week, and then I'll be back for about 2.5 weeks. Yeah, about 1.5 weeks, and then I'll be done with my fellowship. And then after the fellowship ends, we actually have our graduation ceremony on July 10th. It's a lot more lax than like my residency graduation, so it was very small. I actually came to the graduation last year for the previous fellows, and it was just really chill, just kind of like more kickbacky. And at like the program director's home, they brought a bunch of food, a bunch of sustenance. There wasn't like many families there or anything. It was just more so like the fellows and maybe their partners, or maybe like a kid or something like that. And then they did like it was really nice. They had like all of the attendings that they rotated with at all the 4 different hospitals. Majority of them came, and because it's such a small class, like 3 to 4, there was 4 fellows last year. This year it was only 3 fellows. Because it's such a small class, almost all the attendings and nurse practitioners like said something about them, about like, oh, like I really appreciated how so-and-so did this. This is something that we noticed throughout the year. And it's really nice because you get to kind of hear exactly what you did, how people perceived you, and, you know, just commemorate all the time that you spent with them, because it's a very short program. It's only 1 year. Other subspecialties such as cardiology, just 3 years. Such as endocrinology, I think is 2 years. Other things like addiction medicine, that one's another one that's actually 1 year. But because it's such a fast program, not only are you having to find a job really quickly throughout the year, you also don't get to spend as much time with every single hospital, especially since we're rotating between 4 different hospitals. So taking the time to meet those people, get to know them and learn from them is just such a blessing to have. So I'm really looking forward to that graduation. I do have a couple of shifts after I graduate just to kind of, you know, pay for the rent that I'm going to be moving into a new place. I'm actually going to be upscaling. I'll do a video on that later on. But the biggest thing that I have is a wedding for one of my good buddies that I was in residency with at the end of August. And then on September 1st is when I'm going to be starting my new job. So things to come, things to come. So I think in terms of the vision for this channel, some of the things that I'm going to be changing, I'm going to be doing some teaching topics. So on the channel, I have some things coming out like how to use steroids, how to use methadone, how to do a goals of care conversation or lead a family meeting. I'm going to be doing topics like that still, but primarily the channel is going to be in vlog format. And then I'm going to be putting the teaching topic in the video. And then later on in the week, I'll probably just cut that part out and just upload it to the channel so you guys can see that, specifically for people that just want to learn that aspect of things. So it's probably going to be weekly vlog format. Let me know what you guys think about down below. What do you want to see from the future vlogs? I have a lot to share with you guys, and I think when I transition into this attending role, I really want to just show you guys the world of hospice and palliative care, because a lot of people misunderstand that, because a lot of people just misunderstand what palliative care is. And a lot of times with patients, they want to hear about these things, and they really wish and hope that their doctors actually bring this up with them. So it's something that they get caught off guard by, and a lot of family members, specifically the family members of patients that have cancer or end-stage heart failure or end-stage renal disease, they are really caught off guard by not being educated on these things in the future, because we're not immortal. Life is going to end at some point, and we don't have a control of when that's going to end, but we do have control of how that is going to look like, such as with advanced directives, pulse, all these things that really come important at the end of time. So I hope you guys enjoy the channel. A lot of things are going to be changing soon. I'm going to be ending this fellowship pretty quickly. I have a lot of feelings about it, and I do want to do a reflection video and do a dedicated video on what to expect with the Hospice and Palliative Care Fellowship, because there are a lot of things that I didn't expect, and I just really hope to share all that with you guys today. So really long video today. I hope you guys enjoyed today's video. I will see you guys in the next one. Like the video if you haven't already. If you hit this part of the video, hit in the comment section, type down below pineapples. That's how I know you guys reached all the way back here. So I'll see you guys later. Peace. Have a nice day.